Doing well. Yourself?
I am doing well. And I will start by saying good morning. I call the Senate Interim Committee on Mental Health to order. It's Wednesday, September 23rd, 2020. This is the remote meeting of the committee. We will start with a roll call of the members to identify who's present and how they are participating. Committee members, please unmute yourselves and state that you are present and state whether you're participating through video or for phone. Committee assistant, will you please call the roll?
Senator Gelser?
I'm here by video, but do not have my camera on.
Senator Hurd?
Hurd here on the phone.
Senator Monis-Anderson?
Senator Monis-Anderson here by video.
Vice Chair Bowles?
Vice Chair Bowles is here by video.
Chair Roblin?
Chair Roblin here by video. So thank you very much for that. Committee members, if you want to ask questions, please use a comment. Please use the raised hand feature that's in Teams to notify me. You can also use the chat room, but do not use the chat room for any discussions. That's part of the record, and the people don't all see that, so it is not part of the record, and so we can use it to basically make sure that I call on you if you have a question, but please do not use it for any conversations regarding what we're talking about today. If you're on the phone, let me know verbally after each panel if you want to ask a question. And you need to remember that for phone, you have to *6 to unmute because you will already be muted. Reminder that the meeting presentations and other materials are posted on OLIS. They've been there for a couple of days, so if you want to look over the materials, they are there and for your information. So we will begin by opening an informational meeting on the Governor's Behavioral Health Advisory Council. And thank you, Steve, for being here. It's really a pleasure. You can introduce the other people who were with you on the panel who may be speaking. So I'll turn it over to Steve Allen.
Good morning, Chair Roblin. Can you hear me?
Yes.
Yeah. Good morning, welcome. With me here is Dr. Solotaroff, CEO of Central City Concerns, who has been my able co-chair for the Governor's Behavioral Health Advisory Council, and also from the Governor's Office, Jackie Yerby. So for the record, my name is Steve Allen, Behavioral Health Director for the Oregon Health Authority, and I just want to thank you, Chair, and members for taking time out of your busy schedules to take a look at the behavioral health system, some of the things that have been going on over the last several months, and want to talk a bit more broadly leading into the 21 session. And I understand we have a PowerPoint that will be up shortly, but that will give me a moment. I think it may be helpful to you, Chair, and members to have identify some themes and some concerns leading into this discussion. So I think it goes without saying that the pandemic has hit the globe hard, the nation hard, and here in Oregon hard, both in terms of the disruption to our day-to-day lives, the impacts on how we would normally live our lives, the impacts on our health, the isolation, the uncertainty, the impacts on the economy. It seems like one thing after another that we've had to work with, and in the middle of that, it's also disrupted how we would normally take care of ourselves in many cases. So the need for behavioral health services now more than ever. And then, of course, on top of it, we've had one of the worst fire seasons in memory, devastating whole towns, and the impacts of that on the people of Oregon. It's also undermined our ability to provide care in many cases and how we provide care. So we've had to shift the modalities of treatment. It's impacted our capacity of care as we've worked to manage facilities and limit outbreaks within our residential facilities and hospitals. All of this is pervasive, and as challenging as this job can be on some days, I don't envy the legislature going into the 2021 session with all the impacts on the economy, the revenue, and those hard decisions that you will be faced with. But we need behavioral health care here in Oregon more than ever, and we need you as legislators more than ever to help ensure that the services that people need here in Oregon can be provided despite all of this. And so you'll see these themes emerge about this difficult time that we're in, and especially in the crossover where you as legislators can have an important impact. One of the themes that I will state just clearly and first is we can't provide the care that people need if our budgets are cut. We've already done some modest budget cutting this year. We'll provide an overview of that. But we're faced with scenarios of 10, 15, 20, 25% cuts in behavioral health care, and frankly, we just can't do the work that people need. We can't provide the services that people need if we're looking at those budget cuts. We also need to transform the system. We need to make it better, and we can't do that facing budget cuts. And so that's a scenario that just will not result in good outcomes for people. Second is we need to invest in our workforce, and we can't provide the services that people need without an adequate workforce. This is human-to-human contact in behavioral health. The services that people need are provided by humans. There is an increasing role of technology, but apps, and remote services still need humans behind them, and we don't have the workforce we need. And it's not just the numbers, it's the training that they need to be able to do their jobs well. It's the supports that they need to stay in the field. Right now, we have too many people who enter the field and don't stay in the field because we don't pay them enough, we don't train them well enough, we don't support them well enough, and so they leave. And we have to recycle the system, and people don't get the skills they need to really provide high quality care without being in the field for years, and we're not doing that well enough. And I remember a statement once heard is if you wanted a shade tree in your yard, the best time to plant it was 20 years ago, the next best time is today. And I know it's inconvenient to look at investments in behavioral health right now, but if we don't do that 5, 10 years from now, when we need those workers, we're not going to have them. We need to take action now to build out that workforce. The third area is we need to improve the system we have. There are inefficiencies. It's ineffective. Access is not simple for too many cases. We're not providing the responsive care that people need. We're not providing the comprehensive care that people need. And we're not driving towards improving outcomes. And we need data to be able to measure those outcomes. We need to know what we buy and what we're getting for what we're buying, and we don't have the systems in place to do that. All of this can be done. We can have a more efficient, more effective set of services in the future, but we need resources to be able to do the analysis and to make the changes, and we can't do that in the middle of a pandemic without the necessary resources to make those changes that we need. And we need to further invest. We started out before the pandemic not having the services that people need. During the pandemic and during the post-fire season, people need these services more than ever. And we have to invest in these services. And again, it's not an inconvenient time, but this is the time when these things are needed. And part of, I think, the work in front of you in a period of time where we have to innovate, we have to make changes in how we live our lives. But I think it's also a good time for the legislature to look at how we fund health care and behavioral health care in particular. So in a period of time where the economy drops and tax revenues drop, it often is the period of time when behavioral health services are needed more than ever, and so the math just doesn't work out. And so respectfully, a request that I would make of the legislature is, let's take this opportunity to look at how we fund behavioral health care so that in a time just like we have right now, when tax revenue is dropping, which ordinarily means cuts to healthcare and behavioral health care services, that we look at other models, other sources of revenues that are maybe more immune to these ups and downs of the economy, so that we don't have a situation just like we're in right now, where we're having to face budget cuts in the middle of a period of time when people need services more than ever. So with that, now we'd like to begin the presentation. Next slide, please. So this is where we're going. This is the framework you've heard me talk about before, and this is the framework that we started the Governor's Behavioral Health Advisory Council work. We talked with all the members about driving towards a system that's simpler for people to access the services that they need, and those services, when they get them, they're more responsive to who they are and what they need, and they drive towards meaningful improvements in their lives. So this was running in background as all of the members and the volunteers who later joined the Behavioral Health Advisory Committee were looking at these areas. Simplicity of access, you'll see some investments in services. We can't have simple access to services that frankly don't exist. So we needed to increase the availability of services. We also have work to do on simplifying the barriers to access. You'll also see themes in which, especially considering our communities of color, which have been deeply impacted by the pandemic, that those services are more responsive to what people need, and you'll see themes around meaningful change in people's lives, that some of that work we didn't get to, frankly much of that work we didn't get to in the Governor's Behavioral Health Advisory Council, but it's also a theme that's pointed to in the Secretary of State Audit's report in terms of data collection and how we drive towards accountability. Next slide.
Good morning again, Chair Roblin and members of the committee. I'm Jackie Yerby, the Governor's Policy Advisor for Behavioral Health. And for those of you who had joined the meeting prior to being gavelled in, you heard me say that my camera is not working. So I apologize for not being visible, but know that I am here. And really appreciate this opportunity to join Steve Allen and Rachel Solotaroff to talk with you about the Governor's Behavioral Health Advisory Council. Just briefly, like in the past, when you'd heard from the Governor's office about the Behavioral Health Advisory Council, you had heard from Tina Edlin in her capacity as the Senior Health Policy Advisor. Prior to Tina's retirement, I was her deputy, and with her retirement, I stepped into this role and stepped into this work that Tina began with the Governor's Behavioral Health Advisory Council. I also have responsibility for many, or I think maybe all, of the health licensing boards, including the ones that license behavioral health professionals. I also work with my colleague, Jeff Rhodes, who has the ADPC in his portfolio. As you know, the Governor brought the Behavioral Health Advisory Council together to build on past recommendations for Oregon's behavioral health system. The council brought together consumers of behavioral health services, tribes, practitioners, hospitals, CCO, and business representatives. I also want to highlight the work that was done to engage people with lived experience. Although I was not involved with from the beginning, since I joined the work in late July, the discussions and deliberations over the past several months were greatly enhanced by the involvement of individuals with lived experience. Steve and the Office of Consumer Activities at OHA held listening and feedback sessions, worked with their Consumer Advisory Council, and had numerous discussions with consumers. The youth voice was prevalent and respected, including a survey and Youth Advisory Council statewide summit to provide input on the direction of the council. Next slide, please. The Governor's charge to the council aligns with Steve's simple, responsive, and meaningful framework. As you know, improving access to behavioral health services and reducing health inequities is a top priority for the Governor. The council adopted OHA's health equity statement to frame its approach to health equity. And just as a reminder, that definition is that Oregon will have established a health system that creates health equity when all people can reach their full health potential and well-being and are not disadvantaged by their race, ethnicity, language, disability, gender identity, sexual orientation, social class, intersections among these communities' identities, or other socially determined circumstances. And recognizing that achieving health equity requires ongoing collaboration of all regions and sectors of the state, including tribal governments, to address the equitable distribution or redistributing of resources and power, and recognizing, reconciling, and rectifying historical and contemporary injustices. Before I turn it over to Rachel and Steve to talk about how the recommendations were developed, I want to recognize that this is not the first set of recommendations related to behavioral health in Oregon. In bringing the council together, the governor sought to build on past recommendations and existing strategic plans to decide on the next best investments for Oregon. In particular, there was an effort to align the ADPC strategic plan, the Tribal Behavioral Health Strategic Plan, and the State Health Improvement Plan. Obviously, the pandemic and its disproportionate impacts on communities of color and tribes have really brought health inequities into greater focus as the council deliberated and prioritized its recommendations. Next slide, please. Now I'll turn it back over to Steve. Could you advance to the next slide? Could you advance to the next slide, please? Thank you. Steve.
Yep, thanks, Jackie. So what you see before you is the map that we created as we went through the initial work with the council. So this kind of mapped out where we were going. On the right-hand side, you'll see in the recommendation that Rachel will talk about shortly is the areas in which we looked at making key investments. I loosely called that the stuff that we needed to improve access and responsiveness of the system. That included housing and supports, services and programs, and workforce. On the left-hand side, these were the dynamic changes to the system that were anticipated that we would look at that would make the system as a whole run better. So we needed to look at what do we collect in terms of data, what are we driving towards in terms of outcomes, how do we increase the accountability and clarity of roles within the system, and how do we pay for things differently in a way that really drives towards improved outcomes. That was some of the work that members, including myself, were most excited about, not just more stuff for the system, but how to have the behavioral health system as a whole work better. And at the core there, you will see the goal of equitable, person-centered, integrated, and being supportive of tribes sort of as a hub for all of this activity, driving towards that as well. As you'll see in the timeline, we were interrupted with the pandemic and weren't able to move into the work that was on the left-hand side of the column, which resulted in, frankly, some disappointment of members, including myself. Our commitment at OHA is to continue that work. We think there's a lot of areas where we can drive change from an agency perspective. We'll eventually need legislative support and probably funding support down the line, but we think that we can continue this work even without the committee and probably bringing together additional groups as we move down. Next slide. So this is the timeline I talked about. As we saw earlier, the governor's executive order came out in October. We had our first meetings in late fall, and then that slide that you just saw with member input, we developed a set of what we called affinity groups, essentially committees, and we began those affinity groups meeting. People self-selected for the affinity groups that they most wanted to participate in, but many were curious or invested in the work done across all of those areas. That work was continuing and nearing completion of that first set of affinity groups when the pandemic hit. And you'll see during that April, May, June period of time, we simply did not have the bandwidth as an agency to support the committee, but also most of the members on the council were also preoccupied with adapting and adjusting to this environment and managing their areas, and so it would have been unproductive to hold meetings during that period. We brought the group back together in July, and because the work of the affinity groups had come together and we had been doing some work in background to price out and to fully capture the work of the affinity groups, we believed at that time, given other work that was about to begin, that we might be in position to wrap up the Governor's Behavioral Health Advisory Council in July. We heard clearly from members that they wanted to spend more time on refining their recommendations, but also to socialize and better understand from one affinity group to the other the overall scope of the work. And so we brought the group back together in July, August, and September to finish that work, and we had our final meeting here and are now just writing up the report, which is due to the Governor's office on October 1st. Next slide. So now I'll turn it over to Rachel.
Great. Thank you, Steve. Thanks, Chair Roblin and members of the committee for having us here. So as Steve mentioned, when we returned, there was a desire to really refine and prioritize the recommendations that we had started earlier in the spring. But moreover, there was a powerful centering and intentionality on racial equity, which emerged in response to what was happening in Oregon and really around the rest of the country. So the Governor's office, particularly grateful to Jackie's leadership with this in support of the council, the OHA and council membership, we took concrete steps to center racial equity in our deliberations in the months ahead. A few examples of that: we set aside an entire meeting in June to have a conversation about race in the behavioral health system and how structures and programs in the behavioral health system perpetuate racism. The council heard from people of color with lived experience on ways that the behavioral health system could be more responsive to communities of color and be more inclusive and representative in policy deliberations. And finally, the governor established the Governor's Racial Justice Council and directed our council to really prioritize our recommendations based on equity, and that these recommendations would then be submitted to the Racial Justice Council for further review and refinement. So we look forward to sending these recommendations to the Racial Justice Council's Housing and Health Equity subcommittees. So with that background, I'll walk through the following recommendations. They were the culmination of all of these conversations, had general agreement from the majority of the council, and are here to be considered for inclusion in the governor's budget. Next slide, please. So as Steve mentioned, our recommendations focus in three key areas: programs and services, housing, and workforce. And each one of those had about three recommendations in prioritized order. So I'll walk through those with you. Starting with programs and services, that group, and with approval of the agreement of the council, recommended a budget neutral initiative to create a statewide crisis system and supporting OHA's ongoing development of a statewide crisis and behavioral health support tool called the Oregon Behavioral Health Access System, funded through CARES Act relief funding. The system will include an all-inclusive web page that connects individuals to all behavioral health services, including crisis, outpatient, inpatient, community-based, and also consolidates, enhances, and expands existing crisis lines to streamline access to crisis services for all Oregonians. Additionally, the system will offer no-barrier, brief emotional support, regardless of language spoken or insurance status. And this is be a big improvement. The system will offer a centralized provider search engine and bed registry. So that's a budget neutral recommendation. The recommendations with budget impact in prioritized order. The primary priority for programs and services are programs that are directly responsive to and driven by tribes, people of color, and folks of lived experience. And these programs focus on peer and community-driven services that also are culturally specific. So specifically, the recommendation for funds to support Medicaid reimbursement of tribal-based practices, which will increase capacity for billing through Medicaid for tribal-based practices. Second, a state-funded pilot to create 3 non-clinical, peer-run respite centers including one that would be a culturally specific program designed to provide services and supports to individuals who are people of color or from tribal communities. Next, expansion of the Early Assessment and Support Alliance, called ESA, a program that's currently 2 years, and the recommendation would be to expand it to a 3-year program. ESA currently provides support to young people aged 14 to 25 who are experiencing symptoms of psychosis for the first time. And the addition of a 3rd year of that program would provide continued transition services, access to strengthened peer support, and overall enhanced life and self-care elements. So approximately 250 youth will be served annually with this expansion. And then finally, to double the program size of the young adult hubs, which provide mental health services, case management, and support for disconnected youth. And OHA estimates that this program will serve about 1,100 additional young people annually. Next slide. The Council's second priority is to fund the Certified Community Behavioral Health Clinic demonstration sites, also known as the CCBHCs, but this would not be at the level of the agency request budget. So understanding state budget's constraints, the CCBHC pilot would not be scaled up, would fund only existing sites, and the agency would work with CCBHC organizations, advocates, CCOs, to look at a sustainable funding model that would support the organizations that can and want to participate. And the goal of this would really be to refine the model, which hasn't fulfilled its pilot experience. Refinements would look at further developing the service array, particularly on culturally responsive service delivery and outcome measurements. Again, the costs here are unknown and would really be subject to the payment model and the sites participating. And then the third recommendation from Programs and Services is a scaled down agency request budget recommendation to increase support for community restoration for defendants who do not have fitness to proceed in a criminal matter, also known as the aid and assist defendants. So this would increase funding for community restoration for approximately 400 clients, and also to fund one additional 16-bed secure residential treatment facility, which could serve 31 to 39 people per year. And we'll see this come up again actually in the housing recommendation. Next slide. So on that, here are the housing recommendations from that group. This group also had a budget neutral recommendation, which is to transfer the Housing for Mental Health Fund to the Oregon Health Authority from Oregon Housing and Community Services. And the idea of this is that it would increase the fund's flexibility to provide incentive funding for capital development of new housing. And this could range from licensed level of care to short-term respite care, all the way to integrated supportive housing in the community. The budget neutral recommendations also would direct OHA to include CCO requirements for navigation for housing and social determinants of health through care coordination. The housing group had the following recommendations with budget impact and in this prioritized order. The Council's priority recommendation is to address housing and community-based living needs by increasing OHA funding for rental assistance that has what we call barrier busting funds as well as wraparound support. So I'll tell you a little bit more about what that means. This recommendation would utilize existing programs and provide immediate support to people with serious and persistent mental illness to access a range of housing in the community. And the funding would allow OHA to contract with more providers and existing community organizations to provide things like tenant-based rental assistance that have maximum flexibility and can be used in a variety of scenarios, from traditional scattered site-supported housing to low-barrier housing models. These funds could provide wraparound services that pair with rental assistance to provide critical things like crisis stabilization, housing and benefit stabilization, connections to more intensive services when necessary. And the beauty of this is that the services would follow the clients even in events when their tenancy status changes. It's not necessarily connected to the unit. These funds could also address financial concerns that might compromise housing stability, things like incentivizing landlords to rent to tenants whom those landlords may consider to be high risk, to help with move-in cost, past bills, and hospitals could also qualify for this funding to help with their transitions of care with a financial matching requirement from those hospitals. The second in this housing and community-based living needs priority recommendation is to create a flexible housing and community-based living fund specifically to fill gaps in the housing continuum for people of color and tribal communities. This could be short-term stability payments to continue in an episode of care, but also to aid in transitions during critical and crisis moments, for instance, when someone's in the emergency department or in an inpatient setting, and that would help to facilitate their transition into the community and housing. The housing recommendations actually also included some suggested target outcomes that may be of interest to you, things like no extended stays in emergency rooms or hospitals because of lack of community placement, no discharges to homelessness, and reduced contacts with the criminal justice system. Next slide. So the second priority recommendation from the Council in Housing, as I mentioned earlier, is to develop additional residential treatment facility and secured residential treatment facility capacity. So in one case, this would be to expand youth adult in transition, to expand the capacity of the youth or young adult in transitional residential system with the addition of 4 5-bed residential treatment homes and a 10-bed secure residential treatment facility specializing in the young adult population, ages 17 and a half to 25. And this expansion would increase residential bed capacity by 30 beds, 90 to 100 young adults once fully operational, but it would depend when the beds come online. And secondly, working off of that recommendation from programs and services, the housing recommendations also would include funding for a total of 3 secure residential treatment facilities to support the aid and assist population. And the housing recommendations also wanted to echo and support that peer respite pilot that I mentioned in the programs and services. Next slide. And then wrapping us up are the workforce recommendations, which Steve referenced, the importance of building and sustaining this workforce starting now, as he mentioned in his opening remarks. The budget neutral recommendation from the workforce group supported by the Council is a critical one to revise the administrative rules, the 309 rules, to reduce unnecessary administrative burden for behavioral health providers in documentation around things like assessment and treatment planning, MOTS data system, other reporting, and really to align the reporting requirements in the specialty behavioral health system with those that we use for behavioral health providers in primary care and other settings. And this recommendation wouldn't need financial support, but would likely require OHA staff to complete the work. In terms of recommendations with budget impact, the Council's primary priority is to create a behavioral health incentive fund for recruitment and retention of the workforce, specifically to increase the number of people from communities of color, tribal communities, and rural communities in the behavioral health workforce. This can be done through increasing capacity through education with bachelor's and master's level degrees, as well as retention bonuses, and looking specifically at under-resourced communities where this workforce would provide care, which include but are not limited to tribal communities, people of color, LGBTQ youth, veterans, bilingual people, and those working in correctional facilities. This incentive fund would also expand funding to incentivize culturally specific peers, traditional health workers, as well as licensed and certified providers and licensed prescribers. The fund would provide incentives at all levels of the workforce in a variety of domains, from loan forgiveness, housing assistance or tax credits, sign-on bonuses, child care, subsidizing dual certification in addictions and mental health with specific focus on rural and vulnerable populations. And finally, the incentive fund would provide incentives for leadership and management training support. In the behavioral health system, we often promote people who are excellent clinicians into management positions without providing the necessary management training to really make them effective in their jobs to support their teams. Next slide. And then finally, the last of our recommendations from the workforce is to, the second priority is to implement and sustain culturally based practices, which include promising and non-traditional practices. And the council notes that implementation of this must reimburse equitably with other behavioral health services and really consider prioritizing services and supports that are outside of a dominant culture paradigm. So this would expand interventions to include culturally based practices, which may be promising practices or non-traditional, and also expand the approved evidence-based practices list to include promising or culturally based practices for coverage by Medicaid. And then finally, the council's final priority is to focus on training. We want to incentivize this workforce. We want to give them the capability to use non-traditional practices and then also to provide ample training. The recommendation is that all of the behavioral health workforce should be trained in trauma-informed care and workplaces, in culturally specific and culturally responsive care, in anti-racism, in equity, and also in interdisciplinary care, particularly working with peers. And as I mentioned earlier, leadership and management training, and then also training in co-occurring disorders in addictions and mental health. And that we would actually develop an outcomes-based system to demonstrate the impact and the uptake of specifically anti-racism and equity training. So thank you for the opportunity to share these recommendations with you, and I will hand it back to Steve.
Yeah, thank you, Rachel. Next slide. So just talk briefly about alignment between our agency request budget and the Governor's Behavioral Health Advisory Council recommendations. Heading into August, we needed to kind of wrap up and package our requests, and we worked to capture those recommendations that, as we were aware of them at the time. So those have been moving forward, but we've also kind of looking more broadly beyond the Governor's Council, looked at other elements of the system that we were aware needed attention. And so you'll see as part of our agency request budget, depending on how that goes through the Governor's vetting process, suggested rate increase for treatment of co-occurring mental health and substance use disorders, knowing that both we want to incentivize that work, as we've talked about in prior meetings, Chair Roblin, but also that this work is more expensive, and so it's a pathway to increase a necessary service that's not available routinely here in Oregon at this point. As part of the Alcohol and Drug Policy Strategic Plan implementation, we included funding for 2 staff to support that work moving forward, and to develop psychiatric residential treatment services capacity. A joint review by DHS and OHA calculated that we need about 47 additional beds. That's above and beyond the secure residential capacity recommendations here from the council. That's for an older age group that is served by the psych res treatment capacity seen here. Next slide. So to just wrap up and think about next steps, we see these recommendations as really important. We understand that there's some uncertainty about whether these recommendations, at least in whole, can be funded at this time. We started this work when the economy was still running along nicely, and we had the largest surplus in the state's history. We know that those conditions have dramatically changed. Still, these are investments that are needed to improve behavioral health care here in Oregon, and the hope is that the legislature find revenue sources to fund all of these recommendations, and especially those that are prioritized. We also want to make it clear that while we didn't get to the second set of affinity groups that would have looked at improving the system as a whole, there are new and innovative ideas that can have a meaningful impact. The flexible housing, community-based living funding. We know too often people who are, especially with the most severe conditions, are challenged in having a safe and supportive place to live. Without that, their ability to sustain recovery and maintain health are dramatically impacted, and so these flexible funds can go a long ways to help overcome those barriers to that housing that folks need. And the Peer Run Respite would be brand new to Oregon. Other states already have this service, including California, Ohio, Pennsylvania, New York. So this would give us an opportunity to build another part of the infrastructure that would be voluntary, that people could choose to seek out these supports and not be under a civil commitment or forced to take them. So they can do that proactively, which we need more of. So in terms of next steps here, these recommendations now move to the governor's office for review. Our report we're putting in final form as we speak. It will also go to the Racial Justice Council for further vetting, refining, and then move forward. So other bodies are also considering those. The System of Care Advisory Council just saw these recommendations for the first time in detail in their meeting last week, and will continue to consider refining and supporting these moving into session. With that, that ends this portion, and happy to take questions here, Chair Roblin, or after the Secretary of State Audit's report, which comes next.
There we go. I think that what we'll do is take a few questions now. I want to personally say thank you to Steve, Rachel, and Jackie. Having been a member of this group, I watched the herding of all of us cats. Everybody came with their own agenda, and to try to figure out how to get from point A to point B with recommendations that were generally acceptable to everybody, and knowing that some people really wanted to go much faster, farther, and other people not so much. So, I mean, it was an interesting group of people. I appreciated the flexibility of the group, especially after we had a timeout, to bring in more voices of those people who were affected, and to listen more directly to what they were their needs to be considered, and the addition of extra people, including youth, to make sure that we filled out the group of people who we were hearing from during the whole thing. So I appreciated that. My Vice Chair, Denise Bowles, was also a member. Denise, any comments that you'd like to make before we move on to the other issue? And then anyway, and I thank you, Denise, because she was there when I showed up. There was Denise also involved. We were in different of the subgroups, so we didn't get to spend as much time with each other as much, but we certainly, I think, had a better perspective of the entire group, and bringing these out of that, I think, were important. So, Denise, any comments?
No, I mean, it was an ambitious group of stakeholders, and it's a lot. There's a lot to do here, and I know that everyone was probably shares the frustration of kind of how things, I don't know, ended, but through no fault of anyone. I mean, obviously, we all understand the nature of the last 6 months. So, you know, there's a lot more conversations to be had, and I look forward to continuing to have those. But really, a lot of really good work by a lot of good people.
Yes, a lot of great voices were brought, and Steve and Rachel, you did a nice job of making sure they felt included. Gave opportunities for a little video that one of the groups made. I thought that was impressive and was important for us to see. So I thank you for your ability to try to make this work. I know that some people were concerned about the process. I don't know how you bring 35 people plus another 35 or however many it all got to be by the time it was all over together without having some issues. That's just not, it's just not a possibility. But I felt really good about what we got to and where we accomplished. If we can get these things done, it will make a big difference, and we're going to hear from the Secretary's audit, and you can put these two together to see that there's some alignment and an understanding of. So I appreciate that. Is there anybody else? I see that Sarah has her hand up. So Sarah, and thank you, Denise, for your comments.
Thank you so much for, oh, sorry.
You're on. Yeah,
okay.
Go ahead.
It's hard not being together, you know, social cues and everything. So, Mr. Chair, thank you, and thank you to everybody that did this work. There's a lot that's great there. I especially appreciate the inclusion of the youth voice. One concern that I have is that when you were before this committee before, both in the fall and during the session and in January, and we talked about the work plan, we talked about the gap for people with intellectual and developmental disabilities who are stunningly absent from all of the slides, from the workforce recommendations, from any of the recommendations. I didn't hear any mention of people from the intellectual and developmental disability community. And I have to say that today, to have that missing, given the significance of those gaps and given the health authorities' record, particularly during COVID, of not providing access to testing for people with IDDD, for not allowing them to the table to talk about vaccines or prioritizing them for vaccines, crisis care standards that denied people access to ventilators, not even counting the deaths and reporting on the deaths and infections of people with IDDD. So my question is, at what point does this population matter, or has the health authority and the state of Oregon just decided this is a subgroup of our population that will never be seen in serious work?
Yes, Senator Gelser, this is Steve. So yeah, we've been watching the impacts and have worked to be responsive to the impacts across multiple populations during the course of this pandemic. And have worked closely with the disability rights folks when we were made aware of situations unfolding, have worked closely with DHS around particular cases and facilities where outbreaks have been happening, and it's not enough, you're right. The work that unfolded over this council was complicated, and the affinity groups were given wide latitude to focus on areas where they believed additional investments were to be made. Some of the work that needs to be done to better serve people with intellectual and other disabilities really is in that second set of affinity groups, integrating the work in ways that haven't been done before. So it's not just availability of services, it's how those services can be more responsive to particular populations, including our communities of color, but also subgroups within our disability groups. That work is absolutely necessary, Senator, and has yet to be completed. And as I talked earlier, we think that there's a lot of work that we can do as an agency to get this next body of work started and elevated and moving forward. But ultimately, we will need your help at some points, either through investments or through legislation to get to that work. And so I don't mean by any of that to say that this got delayed for deliberate reasons or because of ignoring those populations. That's simply not the case. We have much more to do, and I appreciate you holding us and holding me accountable to continue that work moving forward. So happy to have additional conversations offline if you would be open to that.
And Mr. Chair, and Mr. Allen, I'm certainly open to that. I just am out of ideas about where to raise these questions, where to bring the concerns. I've brought them to the committee, I've brought them to you, I've brought them to Pat Allen, I've brought them to the press, I've taken them to the federal government. And it's not just the pandemic, it is overall. And I think in a time when this group is not able to get anything, to be completely absent from a presentation that talks about equity, intersectionality, cultural appropriateness. When I asked before if people with IDDD could be at the table, we were told there were too many people, and yet affinity groups were added, and to my knowledge, no person with an intellectual and developmental disability with lived experience being trapped in a hospital where nobody will provide services to them has been brought to that table for a discussion. So I know the work is hard, and I really do appreciate the good work that is in there, but at some point, the Oregon Health Authority, across all of your departments, public health, mental health, Oregon Health Plan, needs to accept that people with intellectual and developmental disabilities exist in the state of Oregon, because right now, on every front, they are shut out, ignored, and they don't even reach out to Lilia Tenenty, who is the director of the Oregon Developmental Disability Services. Even now, people don't know at the Health Authority who that person is, and I've heard that they only call ODDS when I raise a question at a hearing or write a letter. So there has to be a point. I'm going to go away someday. These people are Oregonians, and they deserve services and support, and they shouldn't always be invisible. I do appreciate the rest of the work, but I hope this can change. I don't like that I have to say this at every hearing, and what the worst part is the way that these people are suffering and disregarded and made invisible by the Oregon Health Authority. Thank you.
So I want to say I appreciate your voice, Sarah, immensely. I also would say the only place where I felt that it clearly came out in these conversations, because I agree we didn't have a lot of people with lived experience in that particular area, was in the idea of raising fees for people doing multiple, people that had multiple identified issues. And so in that particular case, we did talk about people with IDD and other mental health issues, and raising the level so that they could get reimbursed that rate, at least for, and training people in multiple areas so that they could actually attend to those issues. Because as we all know, it is a special person with special training that works cross-sectionally with those individuals and the other kinds of things. So I appreciate, Sarah, your dogged determination to make sure that these get addressed, and I appreciate the fact that you are also acknowledging that there was a lot of good work done, as there's just an issue about leaving some people behind, and I understand that, so thank you. So, Denise, I see Senator Monis-Anderson had her hand raised, and then we'll come to Denise.
Thank you, Chair, and Mr. Allen, another group that I know we have the Governor's Task Force on Drug and Alcohol, but the people, there are so many existing support groups for persons in recovery, and this COVID, this pandemic has really affected those groups. And I happen to know a couple of people in support groups. They're ignoring basically the not meeting because they have been meeting. They need that to survive, and the couple of people that I've talked to, they're very aggressive. They said, no, we will just backtrack if we can't get the support we need from our support groups. So they are meeting. I keep saying, make sure you wear your mask, make sure you wear your mask, stay socially distanced. But I'm not sure how that fits into the strategic plan, because we also have another work group, the governor's work group. But hopefully, you know, that population is a part of the behavioral health system, and so I don't want that. I don't want that piece to be forgotten, and so thank you.
Thank you. Any comments, Steve?
Chair Rowlands, Senator Monis-Anderson, yeah, great point. And I think this body has heard me speak before about the importance of addressing both addiction and mental illness. We're not going to do the kind of work that we need to do with both unless we have an integrated system. So there is a modest amount of money in the CARES Act funding that we're currently distributing that is for recovery support services to support that work when folks need to do that remotely, or to provide options for how to do that in a COVID environment. We're also, I think, one of 8 states that has been awarded technical support by the National Governors Association. We're actively involved in work, and Dr. Richardson sits on that work group with me to help build out the strategic plan for the Alcohol and Drug Policy Commission. So we are actively working on that. The recommendations that came out of the Governor's Council didn't focus specifically on addiction, but keeping in mind that per the Governor's executive order, the original decision was to focus on people with serious mental illness, age 12 and up, and who may also have addictions. And so that wasn't the primary focus of this work, but was intended to be included. I think that we can do more around addiction in that second set of affinity groups, where we look at how the system as a whole works, because part of the work we need to do is simply integrate substance use disorder and mental health treatment more frequently and more often to get the work done that we need to.
Thank you.
Okay, Denise, Senator Bowles, okay, you're good, okay. Thank you for this report, and I look forward to seeing how it moves forward. And again, I've offered, if there's legislation that needs to be done, our committee stands ready to help with that. So if need be, let us know. And I will thank all of the members of this group, and we'll turn it back to Steve to talk a little bit about the recommendations that came out of the audit from the Secretary of State's office. So, Steve.
Actually, before Steve goes, this is Jackie Irby, and I apologize for interrupting. I just wanted to thank you, Chair Roblin and Senator Bowles, for your participation on the Governor's Behavioral Health Advisory Council. I joined late toward the end, but just really appreciate the role that both of you played, and then what you shared about your experience during this committee. So thank you very much.
Thank you, Jackie. I appreciate it. So the second of our hearings is on the Secretary of State's Behavioral Health Audit, and so we're going to turn it back to Steve, who has talked with them and looked at the audit. It's been out, so people can see it themselves. But Steve, the floor is yours.
Thank you, Chair Roblin. So if we could have the second PowerPoint, please. And Chair, I think I understood that we had about an hour for this presentation, so just let me know about how much time you'd like to allocate for this, and I can tailor the speed at which I go through this and the content based on what time you'd like to allocate.
So we do have a mental health parity conversation that probably needs a half hour, so if you can do it in a half an hour, and we'll come back when we come back in December and have a little bit more and see where we're at. So thank you for thanks for asking that, because the first one took a little longer than I thought it might, so thank you.
You're welcome, and I can certainly complete this in a half an hour. So next slide, please. So every year, of course, the Secretary of State audits state agencies, and this past year selected OHA, and specifically the children's behavioral health care system, and quickly discovered, and I think rightfully so, that it would be important to look at the behavioral health system, including adults and children as a whole, because so much of it's interrelated together. So this discussion here revolves around the audit report that just came out a couple of weeks ago, and the agency response to that. And as we talk through this together, you'll see themes that we have been talking about in the prior conversation that will be elements through here. So we have a commitment to engagement on the audit findings, and to be truly effective, change must be led by the people whose systems, who use those systems and their supports. For too long, we've been making decisions without doing enough to involve those people impacted by them, and especially our tribal communities, communities of color, but all throughout, and including people with serious behavioral health conditions. So the users need to have a much greater role in helping us shape how the system works so that we can be responsive to their needs. And We are committing as an agency to partnering with people who use these services and supports to co-create solutions, and we need your help as lawmakers to implement these recommendations. Next slide. This is more about the audit. The auditors look back over the past 2 decades, and so this wasn't just about the system as it exists today. They were very deliberate in working to understand the trajectory of how services have evolved over the last couple of decades, and the work that had been done previously to understand the situation as we have it before us. And the audit was published on September 9th. It's available on the Secretary of State's website, and it includes about 40 pages of their assessment, but an additional 40 pages of our response. I think we were told that the first time that an agency response matched the size of the report itself. We took the response very seriously and wanted to include a variety of types of information as we look forward to planning to address the issues that were raised. Next slide, please. So here are the main findings, and for us, just as a snapshot, this is no surprise, and I'm guessing it's no surprise to anyone here on this committee. These are themes that have been talked about for years, and so part of our takeaway is nothing new here, but these problems are persistent, and they are apparent, and they're here today with us as they have been for years, and in fact, in some cases, decades. So we have real problems with our data. We've been running blind, frankly. The current system that we have, the Measurement and Outcomes System, the MOTS, isn't capturing all the information we need. It was never built with all the modules that it needed to be able to do the work that we needed, and it's certainly not ready to handle the next iteration of data collection that I'll talk about a little bit more. But without the appropriate data, we don't know what we're buying, we don't know what we're getting, and it's really hard to make strategic plans with that lack of information. That was highlighted. I've already talked about workforce. We don't have the workforce we need to move the system forward. We don't have the workforce we need, frankly, to provide adequate services today. We need to address the workforce. Without that workforce, we'll never have the system that we need to serve Oregonians well. We have a fragmented service delivery system. We have the county-based system, we have the CCO system, and those two systems aren't well aligned at this point. There's work to be done so that folks know their roles and responsibilities, and then we can hold each other accountable. The agency, OHA, the CMHPs, the CCOs, and other elements of the system. We have to have a system that works better, and that's part of the reason why access is not simple, because it's fragmented. Even if you can access one part of the system, as you move to other parts, it's easy to be lost track of and not be able to navigate that well. We don't have adequate monitoring of spending, especially in our county programs. We need to do more of that. I'll talk more about much of this work was already in process. Much of it was either paused or stopped completely through the pandemic and the agency response. This is one of those areas. And we've had a lack of consistent leadership and vision and governance. They noted the revolving door as agencies have changed structures, as Oregon has had multiple behavioral health directors come and go, and as each agency director and as each behavioral health director has come in, clearly their job is to set a vision, set a goal, but with such a revolving door, it's been hard to have a consistent vision and process moving forward. And as we know, it'll take a decade to have the behavioral health system we need fully implemented here in Oregon, and if we're making changes every couple of years, that work gets interrupted and disrupted. Next slide. So there are 22 recommendations. These bullet points represent themes within that. So there's a need to have a focused strategic plan for behavioral health. We've already talked about the framework that I've put in place, simplifying access to services, making those services more responsive to who people are and what they need, and driving towards meaningful improvements in their lives. We need to do more to articulate how that framework will play itself out, what work we'll start with, and where all that's heading. and to align behavioral health strategic plan with the agency strategic plan. I'll talk more about that in a minute. Working towards consistent definitions, and so what we call things is important, especially if we're trying to measure them and hold people accountable. We need to, there's a lot of cleanup work that needs to be done within our regulations to clarify certain definitions, better data collection and analysis as a theme, improving partnerships and outreach across and especially with our communities of color and people who are consumers of these services, but also including our county partners and our CCO partners and others. We need to address workforce, as I mentioned, how we fund things, I talked about earlier, and strengthening oversight and accountability. Next slide. So our response, as we thought about how to respond to all these 22 recommendations, we wanted to anchor that in our values and in our strategic vision. So it's not just doing things differently, but why, and how does that align with the agency as a whole, where we are moving and where we want to move in healthcare in general. What anchors those decisions and how we do that work is critically important, and we worked to articulate that. How it intersects with health equity, and how we're centering the work and the solutions on our voices of consumers, and the challenges and barriers, frankly, that we anticipate as we move to implement addressing those 22 recommendations. Next slide. In terms of consistent leadership, I think that work has already begun. So Director Pat Allen joined OHA, didn't have a behavioral health department, so the first thing he did is brought the puzzle pieces back together. I think the thinking at the time was to integrate behavioral health everywhere, but the downside to those decisions was there was no hub of behavioral health, no clear leadership and accountability within behavioral health, and so he brought all these pieces back together, reorganized the agency to be able to focus on behavioral health as a specific area, and then hired me a year ago, April, as your behavioral health director to stop the revolving door and to begin to articulate a clear, consistent vision and pathway to move the process forward. Next slide. In terms of strategic planning, we have been working at OHA for a 10-year strategic plan to eliminate health inequities in Oregon by 2030. That work was well along before the pandemic hit and has now been reinitiated, so that work will continue until we have a finalized strategic plan, but is well along. As I mentioned, the behavioral health vision is the care be simple, responsive, and meaningful, and we need to align our ultimate behavioral health strategic planning with the agency goals, so that work will be done in concert as the agency work moves forward. That doesn't mean that we're pausing and waiting for that work to be done, but we are already moving the work forward in anticipation of the agency strategic plans being finalized, and as we work towards our own strategic plan. Next slide, please. So getting into the audit in a bit more detail around accountability and oversight. So the county financial assistance agreements, those are the contracts that we have with each county surrounding their role as providing those safety net services for people with behavioral health care needs. We had already engaged in work with the counties and were doing internal planning and revision work prior to the pandemic. We had anticipated meeting with all the counties, and we were going to do that jointly with CCOs to help ensure that integration and collaboration across the county work and service provision and the CCOs, that work was paused because of the pandemic. And the work to revise those agreements to balance local flexibility and accountability is the way that we're planning to move forward. So we've heard complaints or concerns from the counties that the way we currently fund them, the instruments themselves are cumbersome, hard to understand, hard to follow, but also it helps, it contributes, I would say, to the fragmentation of the system in the way that we divide up those funds. And so they're requesting additional flexibility, which we've talked about in finding ways to increase accountability in exchange for that flexibility as we move the instruments forward. So those will be goals as we reinstitute those discussions with counties ahead of the next cycle. Next slide, please. So another area highlighted by the Secretary of State audits was accountability and oversight of the CCOs. And just as a reminder, there was significant improvements from CCO, what we're now calling 1.0 to 2.0. One of those is that CCOs were able to delegate the full behavioral health benefit, and a number of CCOs did that. It was never intended to delegate the responsibility and accountability from the CCOs. But we've made it much more clear within 2.0 that CCOs can delegate the service provision for behavioral health to other entities, but ultimately the CCO themselves are responsible for the benefit and ensuring that adequate services are provided. We heard loud and clear that the provider network was inadequate under CCO 1.0. There were long wait times for services, which are unacceptable. We need to have prompt, simple access to service, and we weren't getting that through 1.0. So we've clarified the language and increased accountability around ensuring adequate provider network and timely access to care. Under 1.0, members were unable to access behavioral health in the person-centered primary care homes. We've now made two-sided access to behavioral health care and primary care. So for within behavioral health care settings, primary care can and should be provided. That's especially prevalent within our CCBHCs. But within the person-centered primary care homes, behavioral health care must also be provided. So no wrong door. People can now receive behavioral health care, whichever setting that they're in, and primary care as well. These need to be integrated, and we're moving towards that. And limited care coordination under 1.0, and members would often fall through the cracks. That's that system fragmentation, and part of the fix for that is care coordination. We've strengthened the language and the service array within 2.0 so that not only is care coordination accessible throughout, but we've also increased and added a service called intensive care coordination for people with particularly complex and severe conditions. Next slide. Funding. The reports, what we already knew, the behavioral health care system has been chronically underfunded, and we can't have a better system without improving and strengthening how it's funded and the extent to which it's funded. The second bullet is something I mentioned in my opening remarks, is that it makes financial sense from a responsibility perspective to base funding for services on available funds. But as I mentioned earlier, when the economy goes down, it doesn't mean the needs for healthcare go down. And as we see right as we speak, the need for behavioral health services is now more than ever in a period in which our economy is really struggling. And if we base behavioral health care resources on available funding, we won't have the services we need when we most need them. And I think that's exactly where we are today. And so, again, my hope, respectfully, is the legislature considers alternative means to fund areas like behavioral health care that ought to be immune from those ups and downs in the economy. Otherwise, people won't get what they need when they need it. Next slide. So in the earlier set of budget cuts, we were able to mitigate or moderate the impact on behavioral health care. Part of that on the first slide is we had made shifts to residential rates, and we were able to leverage federal funds to offset $28.5 million in general funds through that process. So we captured that. The Oregon State Hospital eliminates a number of functions and eliminated 21 non-direct care positions towards salary savings. And rental assistance and wraparound services, we were funded for those services in anticipation of planned construction of permanent supportive housing, which are not expected to come online until later. And so we were able to just slow that funding down and capture general fund savings as part of that. Next slide. Behavioral health contracts in a similar way, certain elements that were intended to roll out but weren't able to be rolled out as quickly as intended. We put a pause on that and pulled back some of those funds, but not the services themselves. A key example of that in children's side under Senate Bill 1 or 221, intensive in-home treatment will now be implemented in January and not July, and so the savings in those 6 months was captured. Special appropriation for independent assessment teams. This was, I think, originally $10 million, but scaled back to, I think, $5.7 million for assessment teams for especially complex children. That was put on hold. And vacant positions and services and supplies, we were able to generate another $20.5 million in general funds. So as you see, as we look through that list, we were able to mitigate or moderate the impacts on the current behavioral health system through those offsets. Next slide. Modernizing data. As I talked at some lengths that I won't go back to, we've been running blind in our system. The current data system, the measurement and outcomes system, the MOTS, doesn't adequately do the job. We're not getting the data that we need. We're not able to provide meaningful reports, but really where we need to go in the future is to be able to integrate multiple data sets. For instance, we need to better integrate data from DHS and OHA. We need to include education information, law enforcement information, other agency information altogether, so we can see a whole person, whole community in our data sets. And our current data systems don't allow us to do that. Where we're heading, the Compass system will allow us to do that. You've already funded the data warehouse that will be the place where all this data is brought into. The next phase of that project is additional funding now with, I believe, about 75% federal match. So we've been able to convince the federal government to help support this work. We need a modest amount of money to fund the next iteration that will allow us to pull in and to report out the data from those multiple data sets that we plan to pull together. Next slide. Next slide, please. I think our slide deck's become stuck. I think they're rebooting it. Thank you. So workforce we've talked about. So this reports in most respects simply reinforces what we already knew, and workforce is a key area. Progress and resources for change. We've already done several reports now through outside vendors on workforce specific to behavioral health, and then with a focus on our veterans services. Those have already been completed and create a map for to-dos to improve the workforce. We have a behavioral health workforce incentive fund that's been included in the agency request budget and was highlighted in the Governor's Behavioral Health Advisory Council recommendations, which you just saw. And the Oregon Commission on Hispanic Affairs has recommendations. They've been working separately to analyze new data sets and reanalyze data sets that have been available to better understand how to provide where we need to go to provide responsive care to our Latinx communities, and that has clear implications around workforce. Next slide. I also wanted to just highlight briefly concerns around provider stability during COVID. As we know, the pandemic has had lots of impacts on lots of businesses, but also included our behavioral health infrastructure. There was a survey done by the Oregon Council on Behavioral Health, in late June that highlighted at that time about 70% of behavioral health programs reported they were facing either full or partial program-specific closures of billable service levels or relief payments that have been available through the course of this year did not change the current status. 2/3 of the programs had to reduce access or close programming. While initially modest, they reported 35% programs have enacted some staff layoffs, 40% anticipated additional layoffs within 2 months of that survey. 42% of providers have had less than 2 months of operating reserves on hand without implementing layoffs. So I've been pretty concerned as we monitor our programs over the course of the year as some of the federal and other supports that have been available to these programs as we hit fall, winter, or early spring, that we might begin to see some of these programs having to further scale back or in fact close, which would undermine our ability to provide services. So just alerting you to that. We're monitoring it closely, but that may be an area where we need additional legislative action. Next slide. Additional information on this, we've taken a variety of actions. We've provided a lot of flexibility to our CCOs in how they do their work, and additional funding, which in many cases the CCOs have used to help support our provider array. We've given the counties a lot of flexibility in how to spend those money and front-loaded funding on a quarterly basis to help them navigate through these complex times. And we've are in the process, I think, have mostly pushed out $11 million under the coronavirus relief funds to the CMHPs with a special focus on our communities of color and outreach to those populations most impacted by the pandemic. We've worked aggressively to make telehealth available services throughout. So any behavioral health services that would ordinarily have been provided in person can be provided through telehealth, and the payment for those services are equitable. So this will be really interesting as we look ahead. We're learning a lot about how to do that work and the benefits and probably the limitations of those services. And so we're watching with a lot of interest about how that plays out. But we are seeing lots of additional engagement through telehealth with services, and we're seeing a reduction in no-shows in that. So I think that's it's interesting to watch that unfold. And there have been Medicaid vacancy payments through the disaster state plan amendment that have been, and especially hard hit by that have been our substance use disorder programs. There are larger programs in population that are mental health programs, and had to restrict access in part due to maintain appropriate social distancing, which those limitations affected their bottom line by fewer admissions and reduced revenue. So that particular strategy is especially helping to our SUD providers. Providers have also been able to access the Paycheck Protection Program loans, which help them with their bottom lines, and the U.S. Health and Human Services direct provider payments up to about 2% of their annual revenues. Those are all been actions that have helped our provider supports. Like I said, I think so far it's been okay. I'm just concerned as these funding streams may wane or sunset, what the impact will be. Next slide. On the children's system of care, we, through Senate Bill 1, of course, we have the System of Care Advisory Council, which has stood up. The final appointments were made by the governor, and that group has been meeting monthly since March 2020, so building some momentum now. They have a data dashboard that's currently in development, which will be critically important. They've made COVID-specific recommendations to child-serving agencies and have completed a report to the governor with early findings and of course, to the legislature. So their work is beginning in earnest. And as I said, they just reviewed the Governor's Behavioral Health Advisory Council recommendations, which is appropriate to their role. Next slide. The audit and findings also include improved engagement, which I've already talked about. We need to improve our connections between leadership and advisory groups. I think I've mentioned to this body we've recorded some 42 different advisory groups that have been engaged with OHA around behavioral health. And so recommending that we look to help streamline those in a way that information flow is actionable and is efficient and meaningful. So we're working on how to best conceptualize and implement those changes. The next step, the Safe and Strong campaign actually launches today. As part of that, we've been working with Brinks Media to help reduce stigma and improve access. So part of that campaign includes statements and messaging that it's okay to not be okay in this environment, and it's okay to seek help, and here's how you find it. And Oregon is one of a few states where we have a director of consumer activities reporting directly to my position. Brandy Helmsley is in that role, and she's been very active in the Governor's Council and very active in outreach and engagement with our consumers, including multiple times a week having webinars where people from the consumer roles can engage with us and talk about what's working, what's not working, and I am opening office hours to directly speak to consumers beginning next week. And I'll hold those, I think, twice weekly, where I can talk by phone or by video with people from our consumer groups who are interested in reaching out to me with questions or concerns. Next slide. So what's next? Next slide. So we picked out certain areas where we're already aware that there will be some legislative acts. The numbers that you see on the left-hand side refer to the recommendations in the Secretary of State Audits Report. So defining health and mental health, again, we have some cleanup work to do in our statutes. Number 6 is addressing the behavioral health data gaps, including benchmarks. So the funding that I mentioned for the Compass modernization system, that's next phase of that work, will be needed, and behavioral health legislative authority where necessary, including integration with law enforcement information as an example of that, and then funding and continued consultation with a system of care experts. Number 7 was developing deliver a proposal to request additional resources for data analysis. So it's not just that we need better electronic systems for capturing, analyzing, and reporting out the data, but we need people to help interpret and drive that data. So those are that's an FTE position that we plan to request. Next slide. Develop an intermediate proposal to address issues with statutory language on the call center. So if you recall, we have a call center, part of Lines for Life, that was intended to help facilitate provider referrals, and that part of the shortfall of that legislation was it didn't require providers to participate, and so the activity as part of that resource has been lower than it has been expected, and frankly hasn't provided the benefit that was anticipated and requested. And so the System of Care Advisory Council, in their role, is devising recommendations to improve that call center. Optimizing statute regarding mental health treatment, to consider directing a study to help us take a look at where we can improve our statutes, how to make them more efficient and effective for the work that we need to do. And finally, the workforce retention and recruitment strategy with an annual report to the Oregon Health Policy Board, and staffing and funding needed to do that work. I'm told that previously that OHA had within its behavioral health unit workforce staff whose sole job was to look at the needs and within our behavioral health workforce. We don't have that resource currently, and so we're struggling to really keep up with the work that's needed to strengthen our workforce. And that's it for the formal presentation, Chair Roblin. Happy to entertain questions.
Again, thank you, Steve. I'm getting a little feedback. I hadn't seen where that came from. I want to say I appreciate the fact you took the audit seriously, and your response was larger than the actual report. So, I mean, I'm impressed with the work that you're getting done and the acknowledgement of the issues that we need to work on, and we will follow up with this more in December as well. I just want to make sure that we have time to have our mental health parity conversation. And I'd also really like to continue this conversation. We got a couple of questions that I sent to you, and if you can do a written response or something to follow up, we'll share it with our committee. But it was basically around what's happening with actual observations of mental health facilities and so on and so forth. You're going to doing that remotely, and and there are people concerned about that, and I know you would be. And the other one has to do with the equity issue. So we'll follow up some more of those in the future. With that, Senator Bowles, do you want to have a comment before we go to the equity issue?
Yeah, thank you, Chair. Dr. Allen, I appreciate your presentation here. I felt a little bit concerned. One of the most concerning parts about this audit had to do with our kids and the vulnerable populations. And I think there's a key element that I'm curious about, would like to know more about, with regard to the relationship with DHS and how that is working. I mean, you really didn't talk much about that, which I thought was kind of the key piece of, for me anyhow, a takeaway of the audit. And so, you know, broad terms as far as mental health across the board, but especially with our kids and those in very difficult situation. So you know what I'm getting at. So can you just lightly, and this may be another follow-up to have a broader conversation. I know we're pressed for time, but I would like at least an idea of what those conversations look like.
Sure, Chair Roblin and Chair. Yes, sorry, I'm just trying to think of a short version of this. So absolutely right that that's a critical area, and we need to improve the integration with DHS, and that work, frankly, has moved a long way over the last year. Chelsea Holcomb, whose position, frankly, has just been elevated to a direct report to mine and to provide her more resources to do that work. That's been moving along, I think, really well. I think the additional work of the System of Care Advisory Council, that's their job to help improve with system integration to reduce fragmentation and improve accountability. And then the next iteration of the work that we need to do at OHA that I talked about as part of the Governance Council, that system reform work, all of those, I think, will work in the direction I think that you're heading, that you would like us to go, Senator Bowles, and frankly, we need to go to better support families and children in Oregon. Happy to have additional conversations.
Thank you.
Appreciate it.
Thank you very much for both of you. And thank you, Steve. And if we have any time at the end, I don't think we will. We'll do it. We usually have 3 hours. We only have 2 today, so it's cramped our style a little bit. But thank you very much for both presentations. Appreciate it a lot. We are now going to move over to mental health parity. TK Keene, Lori Coiner, and Chris Warner. And they can make sure that I didn't butcher the name too much, but we'll turn it over to you guys for your presentation on mental health parity. Thank you very much. Go ahead.
Absolutely, Senator Roblin, and this is TK Keene, Acting Administrator with DFR, Division of Financial Regulation, and happy to start. There's the presentation. Good morning, Chair Roblin and members of the committee. So again, TK Keene, Acting Administrator with the Oregon Division of Financial Regulation. Wanted to provide the committee with a report out on Senate Bill 860 and the examination results from that Senate bill. So if we could go to the overview slide, please. Thank you. So you might recall that through Senate Bill 860 back in 2017, that required DCBS to examine insurers' practices with respect to pay parity between physical health and behavioral health providers. That bill asked us to look into 4 questions. First, reimbursement for outpatient visits, including looking at allowable length of time for the office visits. Procedures for utilization management. So, for example, things like prior authorizations that may be roadblocks here to getting to behavioral health parity. How reimbursements differed over time between providers, and if the systems used to determine reimbursement or the methodology was similar between the providers. And based on the outcome of the examination, Senate Bill 860 directed DCBS to take necessary steps to ensure carriers meet the requirements under existing state law. Next slide, please. And so in this examination, we looked at fully insured, small group and large group health plans, including student health and association health plans. The data call was required carriers to provide 24 narrative responses and specific data on 15 other questions. And for each carrier, we reviewed information on 35 CPT codes. We ended up with 190,000 different points of data to review. Next slide, please. So the report indicates multiple carriers have implemented practices that result in noncompliance with provisions of state and federal parity requirements, most commonly in the form of the non-quantitative treatment limits. Next slide, please. And so the report findings include, the methodologies used by carriers in setting reimbursement rates were not always equivalent for behavioral health providers when measured against methodologies used for medical or surgical providers. Factors considered when developing behavioral health medical management practices are applied more restrictively than those used for medical or surgical medical management practices. And this is important because using different factors to establish medical management practices or applying the same factors more stringently to behavioral health services allows insurers to start their benefits administration process from a different position, and that can result in greater disparities later in the benefit administration process. Establishment of utilization review requirements that differ between surgical or medical and behavioral health services. So, for example, in some cases, this practice permits insurers to circumvent reporting of adverse decisions by, permitting negotiations between providers and medical management staff employed by the insurer. So, this establishes different protocols for requesting an appeal of the insurer's decision. And finally, the use of alert algorithms to trigger more frequent utilization review. So this is something we don't see in the medical or surgical services space, but did come across in behavioral health through this examination. Next slide, please. So insurers rely heavily on third-party organizations to develop and provide credentialing services, medical management protocols, and benefit development, as well as care guidelines. And many insurers offer more frequent opportunities for contract renegotiation between medical and surgical providers than are offered for mental health providers. What this does is present challenges for network adequacy compliance, since insurers won't know if the provider obligations have changed or if they have more patients than capacity to treat. Additionally, restrictive coding guidelines are in some circumstances limiting access to care. So many insurers have adopted coding guidelines that appear to contradict coding practices that have been adopted by CMS, and that results in restriction or prohibition of the use of certain CPT codes. It is something that we discovered in this examination. This practice introduces some ambiguity for consumers and providers about coverage under the policy for behavioral health services, and it could discourage consumers from seeking needed care. Finally, I just mentioned adoption of different outreach methods with providers to answer questions about claims or authorization requests as being also an issue. So providing two different processes for benefit administration allows practices to develop that are non-compliant with behavioral health parity. Next slide, please. So next steps for us in this work include first, getting the carriers into compliance with existing law, reviewing where we need to perhaps issue bulletins or adopt administrative rules to better clarify the law to the extent that there's any ambiguities for carriers, and also potential legislation. I think this examination was really helpful to us in identifying issues, and there's some really clear next steps to this process based on the examination findings. So DCBS will be convening a stakeholder group to discuss planned legislative concepts for the 2021 session. And some of those concepts, such as network adequacy and data collection concepts, would strike at some of what the examination findings were here. Next slide, please. So with that, I'm happy to answer any questions, Senator or Chair Roblin or members of the committee, or if you want to append until everybody's presented, either way.
I think we'll try to get everybody's presentation and then do some, and I do want to make sure that you realize that we are, our committee is open for legislation if we need to help you with that. So, but let's go on with the rest of the presentations. Thank you. And you're ready.
Good morning. I'm Lori Coiner, Medicaid Director with the Oregon Health Authority. Good morning, Chair Roblin and members of the committee. I'm here to present on the mental health parity within Medicaid and the Oregon Health Plan and what we've been doing over the last couple of years. Can you move the slide forward, please? So just to give a little background, there's a National Mental Health Parity and Addiction Equity Act that was passed in 2008. That law was focused on commercial insurance and did not affect Medicaid. It wasn't until October of 2017 that there was a Medicaid parity final rule that went into effect that affected Medicaid plans. And in this case, it affected fee-for-service and managed care plans. So all of Oregon's, all of the members under the Oregon Health Plan were affected at that time. Next slide. The key areas that the rule, that the federal rule addresses are it limits aggregate lifetime dollar amount limits, financial requirements like co-pays, and then there's these two other big bucket areas around quantitative treatment limitations, which would be, an example would be a limit on the number of outpatient visits or the limit on a number of days a person can be in an inpatient facility. So the point is to have parity for people that are being treated for mental health or substance use as if with the same limits as people who are being treated for a physical health condition. And then the last one is what we call non-quantitative treatment limitations. This is things, a big bucket of utilization management. What we mean there is prior authorization and how services are denied. In our Medicaid program, we do not charge any copays for members at all, so the financial requirements we didn't have to address those, or the lifetime dollar amounts, because we don't put annual or lifetime limits on services in the Oregon Health Plan. So we focused in 2018 on those second two buckets, and I'll talk a little bit more about that on the next slide. So in response to the rule in 2018, the Medicaid program conducted a mental health parity analysis. We conducted it for our fee-for-service program, as well as all of the CCOs were required and participated in an assessment of their mental health parity. We have a report. It's available online. If anyone wants to take a look at it, we'll send the link. I neglected to put it on this slide, but there is a report, and it goes, reports by CCO and our fee-for-service program where we had areas for improvement. On September 12, 2019, we were informed by the Center for Medicare and Medicaid Services that Oregon was demonstrating compliance with the Medicaid rule. Next slide. So here are a few, I guess, key areas that we found deficiencies and made changes after this 2018 analysis. So the first one is that we began to have each of the CCOs and our fee-for-service program ensure that medical necessity is based on evidence-based criteria. Medical necessity is what determines whether a person can get a service often, and so that should be based on evidence criteria and not something else. Then the second thing is there was a need to further standardize the frequency and timelines for utilization management, such as prior authorization, so that those are done in a timely way, and they're not more often by service category, meaning not more often for behavioral, for let's say a mental health service than physical health service. And then also to make sure that the appeals processes that a member can follow are consistent for behavioral health and physical health services. The third was that denial decisions for behavioral health services need to be made by a professional peer, meaning a denial needs to be made by a behavioral health specialist or expert or provider in order to be consistent and provide quality decisions. And then the last one was to create consistent policies for out-of-network and out-of-state limits. So, we need to have consistency across that for both mental health and behavioral health services. Next slide. The Medicaid rule that went into effect in 2017 said that each state needed to assess their mental health parity, report to CMS, but it doesn't talk about what states are required to do moving forward. However, OHA and our Medicaid program did include mental health parity as a component of our CCO 2.0 contracts. So for 2020, the CCOs are required to conduct another parity assessment. We will be doing that with our fee-for-service program as well. And we've contracted with the Health Services Advisory Group to conduct the analysis. OHA will be assessing changes to benefits administration and operations that occurred from the prior contract to CCO 2.0 to ensure that we retain the mental health parity gains that we made in 2018. And the contractor will document the determinations and then develop any corrective action plans as necessary to ensure that the CCOs and our fee-for-service are in compliance. Next slide. I think now I'm just open for questions. I guess the one thing that I do want to note before we move on is that the mental health parity rule for Medicaid does not talk about provider networks. it's really focused on utilization management and out-of-network services and those sorts of things. So we did not look at a broader lens of network adequacy. So thank you very much. Senator Roblin, I think you're on mute.
Thanks for reminding me. We'll move on to our next and make sure we get as much as we can in. We have a deadline of the 10 o'clock a couple minutes before because the same meeting room is going to be used by the next committee. So I will turn it over to you. Have a great time, and thank you for NAMI being a part of this, and let us know how we're doing.
You got more. You have to have more than 10 minutes for that. No, Senator Copeland, Chair Rowland, I'm Chris Bonaff with the State Chapter of the National Alliance of Mental Illness. I'm actually here also speaking on behalf of the Behavioral Health Access Coalition that includes 6 other organizations really working on parity issues. That includes, the psychologists, psychiatrists, LMFTs, LPCs, the licensed disciplines, the counties, our providers on the Oregon Council for Behavioral Health. So this is more of a coalition. We're here not just representing NAMI, so to speak. Next slide, please. Quickly, I just want to remind everybody, why is this an issue? What are we trying to solve? And what we're trying to solve is this. By and large, even with quote-unquote parity, people who need services don't get them, never will get them. But the people who do get services are never going to experience the full benefit of those services. So you wind all the way down to the right corner here, and 5% of the people who need services are going to receive the full benefit services. That's of the 40% of the people who receive services. And the burdens that we are having on all the various other systems, these didn't materialize out of the ethers. We've been doing this year after year for decades, and that is why every system under the sun is overburdened by people who are going with unmet need. And this is what we're trying to get after, get more people not only to services, but effective services, because we don't have effective services widely available. Next slide, please. Part of this also is we need ongoing vigilance around parity across the board because we haven't bothered to try doing this for very long. So again, it was not until 2005 in our state that we really cared enough to say, hey, maybe you should have benefits on parity with your medical benefits. And, really rules rolled out slowly, understandably. It only applied to employer group plans. And so, our first nascent steps into this weren't really until 2007, 2008, 2009. We didn't have federal parity until 2008. Well, we didn't have rules for federal parity until 2013, and there really is no way to enforce that because the federal government doesn't have an enforcement process. So you can't go complain about parity to the federal government and have them take action on plans. Only those plans regulated by the state could the state then kind of come in and apply federal parity requirements. It wasn't until the Affordable Care Act that we had this concept of essential benefits. And you didn't have Medicaid expansion and that really take place until 2014. So it really isn't until 2014 and then with the CMS rule in 2016 that across the board, except for Medicare, where parity does not exist, you have all payers having some expectation that parity and access on behavioral health side are important. So in theory, we've really only bothered to do this in total, except for Medicare, for the last 4 years. And so that needs vigilance. Next slide, please. You talked earlier about the kind of provider rates. Well, this costs Oregonians money. This costs me money. This costs you money if you want to access services. This is an examination by Milliman, who they've been doing this annually for some time, looking at out-of-network utilization and that comparison on a parity between behavioral health and medical surgical benefits. And the disparity is significant, and this is divided inpatient facility. That's basically inpatient psychiatric care. I am more likely, if I need that, to have to pay exceedingly more for my care because it has to be accessed out of network. Outpatient facility, that's intensive care. So think intensive outpatient treatment where I may go every day for a period of time for anywhere from 4 to 8 hours. You compare that to similar facilities on the medical surgical side, and you have a huge disparity. So again, that's money out of my pocket trying to access care that people who are qualified say I need. And then this disparity to me, these office visits, that's routine. This is routine mental health care. And when you compare that to primary care, or you compare it to, say, a referral that primary care may make to a medical surgical specialist, and again, you have a huge disparity. And so while we talk about provider rates, the impact isn't just on access, it's also on what Oregonians have to pay out of pocket to access any kind of care. Next slide. And in Medicaid, again, Medicaid, the concept of parity is relatively new. Oregon we're benefited as a state in that we have better benefits on paper than many states and have for a long time. But the concept of parity and comparative analysis to medical surgical, that's new. And we still, I won't spare you this whole list because all of this is going to be familiar to you. I think one of the big nuts to crack, though, in all this is ending variation from region to region as to utilization management, what services are accessible, how you access those services. I think that's a tough nut to crack, but an essential one as we talk about Medicaid. Next slide. We're not the only state that's been talking about this. So states are taking a lot of action on this. And what they're really getting after is some systematic and routine requirements around parity reporting, mostly on an annual basis, which has not occurred in Oregon and it hadn't occurred in a lot of states. But prior to this year, 6 states and the District of Columbia have adopted these reporting requirements. So that carriers every year have to file particular reports doing a comparative analysis with medical surgical. You have 5 states this year that have adopted new requirements, and so it's really kind of taken off in 2020. In New York, you have this combination where they passed reporting requirements, and then their division issued a draft rule requiring that carriers actually have a parity compliance program at each carrier, and they demonstrate the efficacy and the activity of that program. Even in Texas, where they don't have legislation, they have a draft rule issued around the same thing, parity compliance programs requiring that of carriers. And then I'm going to touch on this more. California has been more aggressive than any other state. They recently, by an overwhelming margin, their legislature adopted a bill that really enacts a more modern and evolved definition of parity, what we were trying to get after when we originally did this, but was more recently articulated. That's sitting in front of Governor Newsom. He has till the end of the month to decide what to do with that legislation. Understandably, he's under a lot of pressure from all sides. But let's jump into what they did. So what California did, the next slide, please.
Sorry, Chris, this is Brian. And
I was going to say, I just got off. I hit the wrong button. We're going to have to close because the next meeting has to come on. So, Chris, I apologize, and we will put you on at the beginning of the next meeting that we have because we need to make sure that this gets done. And I know we have some questions as well, but we don't have any time, and it's about time. Is that right, Brian?
Yeah, and if I know Senator Myers-Anderson said she had a comment, so if people have comments or questions that want follow-up, please feel free to utilize me, and I can follow up with anybody on this topic.
I appreciate that information. It's really been impressive. I wish I'd had a little bit more time today. My other hour would have been helpful, but we didn't have that. So any final words, Brian? But do follow up. Your whole report is in the messaging, so we can go through and look at that as well and ask questions. Lori, I'll give you a last second before we go, and then I'm going to adjourn. So.
Just that I want to thank DCBS for the report. I read it, and credentialing is really an issue that I hope the stakeholders will come up with, as well as the provider network barriers. I've been hearing from providers specifically on their frustration. So that's the only comment I had to make.
Okay, thank you. And we will adjourn this meeting and we'll get back and hopefully have some more time and get back to this conversation because I really appreciate, Chris, your work, and we need to make sure that we get held to the fire. So held our feet to the fire. Thank you very much. And with that, we're going to adjourn. Take care. Bye-bye.